Hi, my name is Dan, and I'm a mental health pharmacist, and today I'm going to be presenting on acute psychiatric emergencies. This first slide here is the table of contents, and these are the three major sections that I'll be covering today. First, I'll be covering what is a psychiatric emergency. Then I'll be covering how to treat a suicidal or homicidal patient. And finally, I will be talking about how to treat an acutely agitated patient. Going along with the three major points or parts of this discussion are the three objectives. So after this discussion, you will be able to define a psychiatric emergency, determine when a patient is at risk for homicide and suicide and create a safe plan, and then construct a plan to treat an acutely agitated patient. Let's get started into the first section, which is what is a psychiatric emergency? Psychiatric emergencies have a few subcategories, and what we'll be focusing on today are what's considered major emergencies. These are considered major emergencies because the patient is at an acute risk of hurting themselves or someone else. This could be if they're suicidal or homicidal, or this could be if they're an agitated or violent patient. Next are minor emergencies, which aren't minor, but just this means the patient isn't at an acute risk of hurting themselves or someone else. And then medical emergencies in psychiatry will not be covered in this discussion. So we're going to focus on the major emergencies. This is important because more and more patients are presenting to the emergency department for psychiatric reasons. So if you look at this image here from 2007 to 2008 to more recent years, the numbers are going higher and higher. So this is due to psychiatric reasons, substance use reasons, and a combination of the two. In addition to having more patients, there's fewer beds available. So when you compare 1970 to 2014, there's a decrease in beds by 77%. So all the beds on this picture were available in 1970. Take away all the pink beds, and the clear beds are what's available currently. Taking this back even a step further, in the 1950s, there were 500,000 Americans confined to long-term state hospitals. And then nowadays, there's only 37,000 beds in the entire United States. The biggest change that happened was medications. So patients with psychiatric illness were institutionalized and hospitalized for years and years and years. And after chlorpromazine, the first antipsychotic, was approved in 1952, and more antipsychotics came out, the lengths of stay aren't that long in psychiatric hospitals. So we used to have large state-funded hospitals, and now we do still have some, but a lot less, and a lot less patients are in long-term psychiatric care. So for the first section, the knowledge check question to summarize it is KS is a 58-year-old male that thinks his 16-year-old daughter has been abused by her uncle. He says that he is going to get his brother back for what he did. The family and police were contacted and state that KS is having delusions and confirm that the 16-year-old daughter was not abused by her uncle. Is this a psychiatric emergency? Feel free to pause and think about it. But yes, this would be a major psychiatric emergency because the patient is either at risk for hurting themselves or others, and in this case, they're at risk for hurting someone else. So that covers the first section of the table of contents, and this is the shortest section. But let's get into the second section, how to treat a suicidal patient. This is extremely important because the suicide numbers are also increasing and very high. So in 2019, 130 Americans died every day by suicide. 69% of completed suicides were by white males, and 50% of completed suicides were done via firearms, so violent means. Next are some of the warning signs of suicide. So it is very rare that someone commits suicide without any warning signs first. So this could be things like talking about wanting to die, feeling guilty, feeling like they're a burden, using substances more than they used to, drinking alcohol more than they used to, redoing a will, giving away prized possessions. Any of these things can be indicators of suicidality. There's some chronic risk factors as well. So prior attempts. If someone's attempted in the past, they're more likely to attempt again. Recent hospitalizations, living alone, having a family history, stressful life events, illness, unemployment. There's some acute factors as well. So suicidal ideation, as you would expect. If someone's having ideations of committing suicide, they're more likely to actually commit suicide. Feeling purposelessness, insomnia, withdrawal, substance use. So the risk factors for insomnia can be quite tricky because someone can have a lot of these risk factors and still not be suicidal. So think of how many patients are and how many people have issues with insomnia and they're not suicidal, and anxiety and they're not suicidal, and substance use, and so on. So what you're really looking for is a combination of a bunch of risk factors or just certain situations that make your intuition want to ask more questions about suicidality. There's a mnemonic to remember some of the risk factors, and it's is path warm. So is ideation, substance abuse, path, purposelessness, anxiety, feeling trapped, feeling hopeless, and then warm, withdrawal, anger, restlessness, mood change. So all of these things can help paint the picture of your patient and paint the picture of who may be feeling suicidal. There are also, on the flip side of risk factors, there are protective factors in suicide. So some considered non-modifiable risk factors are female, marriage, children, pregnancy, being religious, being spiritual, and having easy access to healthcare. So that's extremely important. Some modifiable risk factors are interpersonal support. So having someone who's admitted to inpatient psych might not have a therapist or a psychiatrist or friends that they can talk to about these issues. So these are modifiable because you can set someone up with a therapist or a psychiatrist. Positive coping skills, so that's another thing that's taught at psychiatric hospitalizations. So when you're feeling anxious, when you're feeling stressed, what are some coping skills you can do? Some breathing techniques, going for a walk, exercising, watching a movie, reading a book, so on. And then life satisfaction can change over time, and more life satisfaction is a modifiable protective factor. So now we're going to go into 4 major steps on how to treat a potentially suicidal patient. First, we're going to screen for suicidality. Then we're going to determine the level of risk. Then we're going to determine the appropriate treatment. And finally, create a discharge plan. So first step is screening. How to assess if a patient is suicidal. So at this point in my career, I feel comfortable just asking, do you have any thoughts of wanting to hurt yourself, hurt anyone else? Some people might feel less comfortable, so there are measurement-based care scales that you can use to ask these questions. So your goal here is to build trust and ask the questions to the patient. 3 major scales. One is the PHQ-9. So this is a depression scale, and the last question of this scale is thoughts that you would be better off dead or of hurting yourself in some way. Not at all, several days, more than half the days, nearly every day. If the patient answers not at all, then you don't have to ask further. But if they answer anything else, then you will need to escalate and ask more questions. Outside of the PHQ-9, there are scales that are specific for suicide and suicidality. This includes the Columbia Suicide Severity Rating Scale and the Ask Suicide Screening Tool. Some people don't feel comfortable just asking, don't want to use a screening tool or a scale. So this is a script that can be used if you feel uncomfortable asking this question. So the script reads, I appreciate how difficult this problem must be for you at this time. Some of my patients with similar problems have told me that they have thoughts about ending their life. I wonder if you have had similar thoughts. So this first step is just to screen, to ask these questions. So the next step is to determine the level of risk. So many patients are afraid to bring up if they're suicidal because they're afraid that they will be involuntarily committed to a psychiatric unit. So this is possible if someone is at a high risk, they have an intent to do it, they have a plan. But if it's a mild or a moderate case of suicidality, maybe something like passive suicidal ideation, it's not necessarily the case that that person will be committed. So a mild case of suicidality would be multiple protective factors, few risk factors, limited intensity, no plan, no intent. So your response here should be consult with behavioral health and feel free to escalate. So don't take this on yourself as the provider. Call your manager, call someone else, call 911 if there's no one around. So those are all appropriate responses. If it is deemed to be mild case, they might just be treated with frequent outpatient care, and then your goal is to treat the presenting problems. So if someone is suicidal because they're depressed, you want to treat the major depressive disorder. Next would be a moderate level. So there's some protective factors, some risk factors, limited intensity, may have a plan, no intent. Your response is similar. Consult with behavioral health, find help from someone else to help you with the case, and if it's deemed to be truly moderate, there might just be frequent outpatient care. Additionally, means restriction is added here. So if the patient has a plan to overdose on medications, you might prescribe them just 7-day supplies of their medications. If the patient plans to use a firearm, you might recommend putting the firearm in a gun safe, or having it out of the house, or having a friend take the firearm, and so on. High case of suicidality is when the patient has intense suicidal ideation, has a plan, and has intent to do it. So this is the case where someone can be involuntarily committed to a psych hospital. But it doesn't have to be involuntarily. They can also agree to go to the psych hospital. So in this case, you don't want to leave the patient alone, and you want to reach out for help, call 911, transport with an escort. So again, don't leave that patient alone. So once you screen for suicidality and you determine the level of risk, your next step is to treat the patient. So the first step is determining if the patient needs to be treated inpatient or if they can be treated outpatient. Then you can specifically target the suicidality with cognitive behavioral therapies. Your next goal is to treat the underlying disorder, which I touched on. If the patient has major depressive disorder, treat the major depressive disorder. If the patient has bipolar, treat the bipolar disorder, and so on. A lot of people associate major depressive disorder with suicidality, which is true, but patients with schizophrenia and bipolar disorder attempt suicide more often than patients with major depressive disorder. So it's important to assess for this in many mental illnesses. In regards to pharmacotherapy, one of the first things that I do when a patient has expressed suicidality is I review their medication list. I want to make sure they're not on a bunch of high-risk medications that can be overdosed upon easily. So I check to see if they're on things like tricyclic antidepressants, barbiturates, blood thinners, even if they have a lot of Tylenol or things like that. So that's the first thing I'm looking for. Then I'm going to recommend medications based on diagnosis. So if the patient has major depressive disorder, I'm going to recommend antidepressants. That being said, antidepressants have a black box warning for increased suicidality in young adults. And that is important, and you will pay attention to that, but these medications are still recommended in someone with major depressive disorder, even if they have suicidality. You're just going to be hyper aware of this increased risk. Next are certain medications that have been shown to decrease suicidality. So there's only two, and it's lithium and clozapine. So if a patient has bipolar disorder and suicidality, I might push a little harder to try to get them on lithium. That being said, lithium is a pretty bad medication to overdose on as well. Next is clozapine. If a patient has treatment-resistant schizophrenia, I might push for clozapine. And then the long-acting injectable medications in schizophrenia have also been linked with decreased suicidality. So I don't just want you to take my word for it, so I included some studies and some trials that show this as well. So this study here from 2005 shows that lithium decreased relative risk of suicide by 0.44 in patients of all ages and genders. This is interesting too because lithium's natural. It's a metal, it's on the periodic table, and it is in the drinking supply. So different counties have different amounts of lithium in the water supply. So one study out of Texas looked at the different counties, and interestingly enough, the counties with a little bit more lithium in the drinking water had less homicides, suicides, violent crimes, even rapes. So a little bit of lithium in the drinking water may be beneficial in certain ways. Next was clozapine. So in this INTERCEPT trial, patients on clozapine attempted suicide about half as often as the patients on the other antipsychotics. So clozapine may help decrease suicidal behavior. Finally was a recent study, 2021 JAMA, that looked at long-acting injectable antipsychotics versus the oral antipsychotics in newly diagnosed patients with schizophrenia, and the patients on the long-acting injectables had decreased suicidality. So we screened for suicidality, we determined the level of risk, we know how to treat the patient, and now we have to come up with a discharge plan. First thing you're going to do is reassess the suicide risk. So ask them the same questions. Ask if they're still suicidal. You don't want to discharge a patient until you know that they'll be safe. Next, you want to provide a crisis hotline number, coordinate follow-up, and create a safety plan. So the hip-hop artist Logic had a song that was titled The Number for the Suicide Hotline, 1-800-273-TALK. And after this song was released and after he performed this song at 2 major award ceremonies, there was an increase in calls to the suicide hotline by 6.9%, and this was associated with 245 less suicides. So simply this song and the awareness of this song probably saved at least 245 lives. This number here, 988, is very important. Many people aren't familiar with this, and this is still rolling out, but this is essentially 911 for suicide. So if a suicidal patients. So this number will connect anyone to the suicide hotline. So if you're feeling suicidal or just anything in that regards, you can call this number and you'll be linked to the suicide hotline. Next step after providing the suicide hotline numbers is to create a safety plan. So this is a literal piece of paper, a safety plan that you give to the patient when they leave, and they fill it out too. So this has coping strategies on there. This has people they can call when they're feeling upset. This has the number of their doctor, their therapist, and so on. So it's a really helpful sheet. Whenever things go wrong, the patient will have something to look at and read and utilize some of these steps. So we screened, we determined the level of risk, we treated the suicidality and the underlying causes, and then we created a discharge plan. So I wanted to end this section with some myths about suicide. First myth is asking about suicide would plant the idea in a patient's head. So just like asking about a history of cancer won't cause cancer, asking about suicidality won't or shouldn't cause suicidality. Some people think that there are talkers and there are doers, and this isn't true. Most people who die by suicide have communicated some intent. So most people do talk before they do. If someone really wants to die by suicide, there is nothing you can do about it. So this isn't true as well. So most surveys indicate about 13% of adults in the US have had suicidal ideations at one point in their life, and 13% of people don't commit suicide. So situations change, things change, and people can be suicidal at one point and not be suicidal later on. Multiple and apparently self-injurious behaviors mean that the patient is not really suicidal and is just trying to get attention. So self-harm behaviors like cutting is associated with an increased risk of suicide. Next part is a few slides on how to treat a homicidal patient. So you're going to take similar steps, consult with behavioral health, and escalate. Call 911 if need be. So evaluate the patient for inpatient care. There's going to be a duty to warn, and then there's some medications that actually help as well. So lithium and clozapine help with homicidality as well and violent behaviors. Second generation antipsychotics, although not first generation antipsychotics, but the second generation antipsychotics do help decrease violence as well. And then there's a little bit of evidence for some other mood stabilizers as well, like valproic acid. So depending on what state you're practicing in, some states have mandatory duty to warn. So if the patient says they're going to hurt someone else, you have to warn that other person. Depending on the state you live in, the laws vary, and some states don't have duties to warn. Next knowledge check is a patient calls into the pharmacy to ask how expensive her insulin will be. She is told $178. She says, it would be a lot cheaper if I just jumped. How would you respond? Ask her for her phone number so you can look for less expensive options and you will call her back. Ask for her phone number and let her know that you will review with her manager and call her back. Ask her follow-up questions, keep her on the line, call 911. So feel free to pause. And the answer is you want to keep her on the line. So you don't know how serious this suicidal statement is at this point, and hanging up would not be a good idea. Keep her on the line, ask her for her location, ask where she is, escalate to 911 if need be. Okay, so we covered what is a psychiatric emergency, especially focusing on major psychiatric emergencies. We discussed how to treat a suicidal or homicidal patient, and we will end with how to treat an acutely agitated patient. So an example of this would be a 20 to 25-year-old male is brought into the ER by police after swinging a baseball bat at passing cars on a busy road. He is currently in restraints and in need of treatment to prevent him from hurting himself or others. So the first step in treating an acutely agitated patient is to obtain as much information as you can. Then you want to utilize non-pharmacologic treatments and safety measures. And then if you need to use medications, you want to first try oral if possible. But if the patient is really, really agitated, you might need to progress right to an injection. Key features of acute agitation would be restlessness, irritability, heightened response to stimuli. And then going along with this is key features of acute psychosis, which is delusions, hallucinations, disorganized speech and behavior. So the similar symptoms to schizophrenia, just more acute and more severe. So you want to obtain a history. So maybe that patient swinging the baseball bat on the street had a wallet in their pocket, and you can ID them and look them up in the medical record. Maybe they've been to the hospital before, and you can determine a diagnosis, maybe some medications they've been on in the past. If they don't have that, maybe there's some collateral information. So maybe their spouse is with them, or a friend in the emergency room, or someone who can fill in some of the gaps in the story. Next is a physical exam. So check to make sure there's nothing physically going on with the patient. Maybe they have some wound or some blood loss that's causing the confusion and the agitation, or maybe there's something else going on. If you're able to get laboratory values, those can be quite helpful. And if you're able to get a drug screen, that can be quite helpful as well. So obtaining information is very important because you don't know why this patient's presenting. Are they presenting because they're on substances? Are they presenting because they have untreated mental illness? Are they presenting because there's something organic going on, like a traumatic brain injury or a tumor? So after you obtain as much information as you can, you're going to want to start with non-pharmacologic treatments and safety measures. So you want to ensure safety of the patient and the staff, remove dangerous objects, and you want to have access to the door. So for example, if I'm talking to a patient in their room, I want to be the closest one to the door, just in case the situation escalates, I can leave. You don't want to be trapped in a room by someone who's agitated. Next, you want to try non-pharmacologic managements like verbal de-escalation and stimuli restriction. Dim the lights, make it as quiet as you can, and so on. Physical seclusion or restraints may be needed in severe cases. And no, there's not straitjackets or dollies or muzzles or anything like that. The patient's simply on a regular hospital bed, and cloth straps are used at their wrists and ankles to keep the patient and the staff safe. Additionally, this has to be done with a physician there. A physician has to go and actually assess the patient. They can't just put in the order remotely or anything like that. So there's some other safety measures as well when a patient's put in restraints. So maybe these steps don't work. You may need to progress to pharmacotherapy. Your goal is to start with oral medications. Examples would be benzodiazepines, first-generation antipsychotics, and second-generation antipsychotics. If you know the patient's background, you can tailor the medications to the patient. So say you know they have bipolar disorder, you might use a benzodiazepine, a second-generation antipsychotic, but you might load something like valproic acid as well. So your options can vary depending on what the patient has. But if you don't know, you might stick with these medication classes to start. Sometimes patients are so agitated that they're not going to agree to take oral medications. They won't answer any of your questions, so you might have to progress to an injection. Intramuscular formulations are recommended if oral formulations can't be used, and sometimes even IV medications are used in severe cases. But luckily, the medication classes are the same. So benzodiazepines, first-generation antipsychotics, and second-generation antipsychotics. We did add one medication here, which is ketamine, which can sometimes be used in acute agitation. Here's a slide specific for bipolar acute agitation. So you'll see first-line recommendations include benzodiazepines, antipsychotics, and then second-line agents include antipsychotics as well. Something to note here is some of the formulations. So there's a Loxapine inhaled product, and there's Asenapine sublingual. So we're having and seeing different routes of administration here, which I'll go over shortly. Agitation and acute psychosis, you want to start with antipsychotics. Generally second generation if possible, and generally oral before parenteral if possible. Here are a list of some potential first and second generation antipsychotics that can be used in acute agitation. Next, I wanted to do a medication spotlight of some of these med classes. So benzodiazepines, first generation antipsychotics, second generation antipsychotics, and then anticholinergics, and then a brief slide on ketamine. So here are two IM, meaning intramuscular, benzodiazepines. We have lorazepam and midazolam. So lorazepam has a little bit longer of an onset, but it lasts for a longer duration, whereas midazolam has a very fast onset, but lasts for a shorter duration. So each of these have benefits and not benefits. I wanted to spotlight this class a little bit. So benzodiazepines are GABA-A agonists. So GABA is the primary inhibitory neurotransmitter in the brain. So agonizing this slows things down in the brain. That's why benzodiazepines are good for acute agitation, seizures, anxiety, alcohol withdrawal, insomnia, more than that. So benzos have many uses. Additional GABA-A agonists are things like barbiturates, and alcohol and is actually a GABA-A agonist as well. Available formulations are IM, IV, and PO. Some considerations with benzodiazepines is that IV formulations have propylene glycol as a solvent. So repeated administrations can cause propylene glycol toxicity. Next, if the patient has hepatic dysfunction or is elderly, their CYP enzymes in their liver won't work as well. So you might want to pick a lot benzodiazepine, which means lorazepam, oxazepam, or temazepam. Some things to monitor with benzodiazepines are drowsiness, so these are sedating, dizziness, they can contribute to falls, and these are controlled medications. So you want to look for patients that might be using these medications inappropriately. Next, I wanted to highlight the first generation antipsychotics. So here are some of the IM options. You have chlorpromazine, droperidol, fluphenazine, and haloperidol. If you boil down the mechanism of first generation antipsychotics, these are D2, meaning dopamine 2 receptor antagonists. These are dirty drugs though, and they also block histamine, alpha, antimuscarinic receptors, and so on. Here's some available formulations, and some considerations for the first-gen antipsychotics are potency. High potency agents are things like haloperidol. You can tell something's high potency because the milligrams will be very low. So haloperidol 5 is a common dose. This is a high potency agent. Chlorpromazine 100, 200 is a common dose. So this is 3 digits in the number. This is low potency. Knowing the potency is helpful because this can help you to predict certain side effects. So a high potency antipsychotic blocks dopamine strongly, has more EPS and some of the stiffness and things like that, but less anticholinergic side effects. Whereas a low potency agent like chlorpromazine might have less EPS, but more anticholinergic side effects. I wanted to highlight 2 medications here. First is Loxapine. So this is a first generation antipsychotic that the oral formulation's been used for a while, but now there's an inhaled version. That's what makes it unique, but there's also a REMS program, which is a special risk program that certain medications have. The inhaled formulation here is FDA approved for acute agitation in bipolar disorder and in schizophrenia. The issue with the medication is that there's multiple steps the patient has to do. They have to exhale, put the device to their lips, inhale, hold their breath for 10 seconds, and in someone who's very agitated, this might be difficult to do. Additionally, there's a risk program in place for this medication because it can cause bronchospasms, and your facility needs to have the ability to intubate. So this can be very serious. So part of the screening before you use this medication is to ask the patient if they have asthma, COPD, if they are wheezing, things like that. So there's a lot of additional steps in patients that are agitated, which can be difficult to do. Next is Droperidol. So this is very similar and related to haloperidol. I've only seen this used in the emergency room for acutely agitated patients. Like I said, it's very similar to haloperidol, but the difference is it has a specific black box warning for QTc prolongation. So this is something that you would certainly pay attention to in patients with cardiac dysfunction and even patients without. Next medication class to spotlight is for second generation antipsychotics. The IM options include olanzapine and ziprasidone. The biggest thing to note with olanzapine IM is this can't be given at the same time as intramuscular benzodiazepines and generally have to be split by at least an hour for fear of respiratory depression. So this takes away some concomitant medications that you can use. If you boil down the mechanism of second generation antipsychotics, these are D2 receptor antagonists, but now they also work on serotonin as well, 5-HT2A antagonist. These are also dirty drugs, and they block alpha, histamine, and muscarinic receptors. Some formulations are listed here, and this is where I wanted to highlight the difference between sublingual and ODT. So sublingual products are absorbed in the oral mucosa under the tongue. Orally disintegrating tablets are disintegrate in the mouth, but they still must be swallowed and they're absorbed in the GI tract. Things that you would monitor with second generation antipsychotics include extrapyramidal symptoms, QTc prolongation, and metabolic syndrome. These can sometimes cause a lot of weight gain. I wanted to highlight Asenapine here because this has unique routes of administration. Like I mentioned, this is available sublingually, and this is also the only antipsychotic available as a patch. Finally, I wanted to highlight anticholinergics. So these are frequently used in combination with antipsychotics in an acutely agitated patient. And the benefits here are twofold. So one, they're a little sedating by themselves, and two, they can help prevent or treat EPS, the extrapyramidal symptoms from the antipsychotic. So if you give the patient a lot of haloperidol, they may get stiff. If you give them a lot of haloperidol and a lot of benztropine at the same time, they have a less likelihood of having that stiffness or having that EPS. Anticholinergics are anticholinergic and antihistaminic. They're helpful in sedation and EPS treatment, like I said, but they're harmful for overall brain functioning. So you don't want to use these for long periods of time. They can lead to confusion, falls, and other anticholinergic side effects like constipation. So finally, I wanted to discuss the combination. So there's a very common combination of these medications in acute agitation, nicknamed B-52, because you're, I guess, like the B-52 planes, you're bombing the person with medication. So this is a combination of 3 medications, and I actually like this nickname B52 because it gives you all the dosings for the medication. So it's haloperidol 5, lorazepam 2, diphenhydramine 50, all given together. So you have the 50 with the diphenhydramine, you have the 5 of the haloperidol, the 2 of the lorazepam, B52. Finally is ketamine. So ketamine's gaining some steam in this area of acute agitation for the primary reason that it works really quickly. It works faster than IM benzos, works faster than IM antipsychotics, so it works really quickly. About 20% of patients see improvement in their agitation within 5 minutes of being administered ketamine. This has a unique mechanism too, so it's different than our benzos or our antipsychotics. This is an NMDA antagonist, and it's a general anesthetic. So now we've looked at the 4 parts of treating an acutely agitated patient. Obtain information if you can, utilize non-pharmacologic treatments and keep yourself safe, use oral medications if you need to, and then use injection medications if the patient's very severe. So this finishes the 3rd section of the presentation, and I wanted to end with a final knowledge check question. So a patient is acutely agitated. The patient tells you that they cannot swallow large pills, but they will take anything to help them calm down. Which of the following do you recommend? Risperidone ODT, haloperidol IM, aripiprazole IM, or Loxapine inhalation? Feel free to pause, but I think the best answer is risperidone ODT. So they can't swallow large pills, but this dissolves in their mouth, so they just have to swallow a little bit of liquid. Haloperidol IM, the patient's answering your questions, responding to you. Doesn't seem like they need an IM. Aripiprazole IM doesn't exist anymore, and Loxapine inhalation certainly is an option as well, but due to that risk of bronchospasm, I don't know if I would start there with my recommendation. So in conclusion, we went over psychiatric emergencies, we went over acute suicidality and homicidality, and we went over acute agitation. I hope this presentation was helpful, and thank you so much for watching.